From where do you come from?
Yeah, should be okay.
That's great. That's when I introduce you as here.
So I just, okay. Hello everyone. Thank you very much for coming to my talk. I'm super happy to be here presenting at the OEH seminar and share with you what, okay, sorry. And share with you what I have done in the past 5 years. First of all, I would like to thank all the individuals and organizations that make my research project possible. They include my co-supervisors, Dr. Sarah Henderson and Dr. Michael Brower, my committee members, Dr. McGraw and Mr. Refuse, and my funding agencies, Australian Research Council Linkage Projects and the BC Lung Association, and help from Pop Data BC and BC Emergency Health Services for my data request. All the friends, classmates, and lab mates that provided me with moral and technical support. And last but not least, my family support that without which I won't be able to finish at all. As you may know, our climate is changing. Under climate change, wildfires are becoming a new normal in our life. They are becoming more intense and more frequent, especially in regions like North America, Russia, and Australia. Wildfire smoke leads to some of the worst air quality most Canadians ever experienced. I like using this photo to show how dramatic the difference was when the left is the usual Vancouver, very clean, but on this specific day in 2015, the whole city was blanketed by very thick smoke. And on that day, the daily average concentrations of PM 2.5 fine particulate matter was about 10 times of the usual range in this region. Wildfire smoke is actually a very complex mixture of different gases and particles, but PM 2.5 is a proxy pollutant for wildfire smoke in most studies so far. We use it because it's small enough to get very deep into our lung and get into our system to cause any symptoms or reactions from our body. And it is also small enough to remain suspended in the atmosphere for a very long time so that it can travel long distance and affect the air quality in areas far, far away from the actual fire. And it is also a regularly measured pollutant. When we talk about the current evidence on the health effects of exposure to PM 2.5, either from urban sources such as traffic air pollution, industrial emissions, or from wildfire smoke, we have to define the time scale first. So we can talk about what's the evidence for chronic exposure to PM 2.5. So this is measured as years or months of exposure. at this time scale, there for urban sources, for PM2.5 from urban sources, there's been very extensive evidence on its impact on disease development. But from wildfire smoke, there is still very, very little evidence on exactly what the long-term effect is. And then we can scale down to short-term exposure measured by days. At this time scale, for both urban sources and wildfire smoke, there is pretty sufficient evidence on disease exacerbation. So it makes the conditions worse for people who already have that conditions, such as asthma or heart diseases. And then we can still zoom into sub-daily exposure measured by hours. At this time scale, for both urban sources and wildfire smoke, there is still very little evidence on this very acute health effect. And this is what my PhD thesis is about. And here is an example of how the daily distributions can be, how different the hourly distributions can be for the same daily average PM2.5 during wildfire smoke events. And because wildfire smoke can change very rapidly within a day. So here, if you look at the top panel inside this red box, on this day at Burnaby, the daily average PM2.5 was 51 micrograms per cubic meter. And on July 9th, at the bottom panel, on July 9th at Squamish, this daily average was also 51 micrograms per cubic meter. So if you're looking at a study that looks at daily average exposure to PM2.5, these two situations will be treated as the same. But if you look at the hourly distribution within the day for these two situations, you see they're actually very different. For Burnaby, on this day, the median of the hourly PM2.5 was 15. So it's a lot smaller than its mean, which means it is right-skewed distribution. So the majority of the mean exposure was coming from just very few hours of extremely high concentrations. But for Squamish, the median is almost the same as the mean, so it means that it's pretty evenly distributed. It has a normal distribution. So these two was, when you look at the hourly exposure, was actually very different. So that's why it got me interested into looking at this issue. To study the sub-daily exposure, there were actually two challenges, which were to measure the exposure to PM2.5 during wildfire smoke events and measure the outcomes with high enough spatial and temporal resolutions. So we're talking about hourly, down to hourly measurements. So here is the structure of my thesis. There were 5 chapters, but I will only talk about the last 3 in this talk. And the first part is to trying to address the first challenge, which to measure the exposure to PM2.5 during wildfire smoke events with high enough spatial and temporal resolution. And what I did was to develop a model to estimate the 1 hour smoke exposure. First of all, just a bit of an introduction on what are the currently available ways to measure smoke exposure. The first one is to use the ground air quality monitoring network. These measurements are usually pretty robust, and they have quality assurance most of the time. They have usually pretty high temporal resolution. In BC, most of them were reported in hourly concentrations. However, they are usually spatially sparse. They were only located in regions where there were lots of people, urban centers. But wildfire smoke can often affect populations that live in rural or remote areas. And then the second commonly used tool is remote sensing. So satellite images of fires or smoke. Their advantages are that they have very large spatial coverage, and they have relatively high temporal resolution, usually 4 times a day, or even there are some satellites that can have images every 30 minutes. However, one of the big limitations for using remote sensing to measure smoke is that it does not measure the ground level concentrations. So they look at the earth from above, and they always measure the smoke in the total column of the atmosphere. So you don't have an idea whether that smoke is on the ground that's related to public health, or it is up in the atmosphere that's probably not affecting our health. And the third tool is modeling. And to model smoke exposure, there are 2 major approaches. The first one is to use deterministic models. Deterministic models tries to simulate the entire physical and chemical process of fire activities, how much smoke is emitted under what kind of fires conditions, and then how the smoke is injected into the atmosphere, and how they disperse, how they're getting transported. And so far in Canada, there are 2 these kind of deterministic smoke modeling system, and they are both forecasting system. They are the Blue Sky Canada Smoke Forecasting System and the Firework Wildfire Smoke Prediction System. These models, they are usually quite expensive to develop and to run and maintain. So it is hard to have them everywhere. And then the second way to model smoke exposure is to use empirical models. Unlike deterministic models, empirical models does not try to explain the entire process, but they just use historical data and derive a statistical relationship between your input variables and the output of your interest, and use that relationship to make predictions. They're usually inexpensive, and depending on your input variables, they can be globally transferable. One of the example of such a empirical model for smoke is the optimized statistical smoke exposure model. We call it AWESOME, 24 hours. that we developed at the BC Center for Disease Control, which used data from the monitor, remote sensing aerosol, remote sensing fire, remote sensing smoke, and meteorology data to estimate the 24-hour average PM 2.5 during wildfire seasons for all populated areas in BC. And in this chapter of my thesis, I am trying to expand on awesome 24 hours to develop an awesome 1-hour system that can estimate hourly exposure to PM 2.5 for BC by including variables with higher temporal resolution and include variables that are relevant to vertical distributions of smoke. So as I mentioned before, one of the limitations for using remote sensing products is that you don't have an idea of the vertical distributions. So this part was actually addressed in the second chapter of my thesis, which I am not going to discuss here. But if you're interested, you're welcome to look at the paper that I published or ask me. And so I used we'll use the variables identified in chapter 2 that's relevant to vertical distributions of smoke to improve the performance of this smoke model. And also, instead of using conventional linear regression methods, we use a machine learning modeling approach to model the relationship. A machine learning approach has some advantages, which is that it can explain very complex relationships. The relationships can be nonlinear, or it's better explained by high-dimensional interactions, which are hard to model using conventional linear regressions. It usually produces better predictions. However, the downside is that there's very limited interpretability for machine learning. You can think of it as like a black box, some kind of black box, that you have your input variables, you have your machine learning model, and you get pretty good predictions from using that model, but it is very difficult to figure out how each input variable affect the final predictions. So that is one of the limitations of these kind of models, is its limited interpretability. But our goal here is just to have good predictions. That's why we choose to use machine learning. And the study area is all the populated areas in British Columbia. And the study period was all the wildfire seasons from April to September in 2010 to 2015. And here is a map of BC, and you can see these gray cells are all the populated areas, and we will make predictions for these areas. And you can see these large fires in these 5 years were mostly concentrated in clustered in central interior and northern interior of the province, and there are also some that's near Whistler and Squamish. So the variables in the model include the response variable we used was the PM measurements, PM 2.5 measurements from the 72 monitoring stations in the province. And predictive variables include the calendar month, the ecozone classification from the biogeogrammatic ecosystem classification map, which is a classification based on the major vegetation species in the area and the climate. And then there's the elevation of the location. And we also have the predictive variables related to fire activities using the fire products from this MODIS satellite. They mostly indicate the intensity of the fire using the fire radiative power. And we also have like the distance to the closest fire, or what's the direction of the fire to your prediction cell. And then the next group of variables are the variables related to meteorological conditions, including the planetary boundary layer height, which is related to how stable the atmosphere is, which can affect how the smoke is dispersed. And also a couple of variables related to wind speed at different altitude of the atmosphere. And then the machine learning modeling approach that I was talking about, we use what's called the random forest. As its name indicates, it is an ensemble of regression trees. So you can think of it as, so here, like there's a forest, and in here, this is sample one is one of the trees in this forest. To train this tree, you will have a random subset of observations from all your training data and a random subset of your predictive variables. And in this tree, you use that random subset of observations to train this tree, and the rest of the unsampled observations, we'll call it as the out-of-bag subset. And after you train the tree, you can make predictions for that out-of-bag subset of data. And because you have multiple trees, you will have each single data point will be in the out-of-bag subset multiple times. And the final predictions for a specific data point is the average of all these predictions from different trees. When you compare the out-of-bag predictions and the actual observations, you can have a sense of how well your model is performing. So here is the performance of my model. The final model has a correlation of 0.93 and a root mean square error of 9.34 micrograms per cubic meter when compared between the out-of-bag predictions and the observations. And if you look at the performance stratified by fire activities within the province, you will see the model performed best when there were lots of fire activities in the province, and a little bit worse when there's modest fire days. And then it performed the least in the low fire days. But overall, the correlations are reasonably high. Let's see. And we also look at two case studies. Case study one, we look at the central interior areas, and the second study, case study, looks at the southwestern part of BC, which include the Greater Vancouver area and the Greater Victoria area. And here is a pretty busy figure, but I'll try to walk you through it. The left column are the time series plots comparing the predictions in gray bars from our model, and the black line of the actual observations at the same locations at Williams Lake, Prince George, and Burns Lake. And as you can see, the predictions follow pretty well with the observations in temporally. But you can notice quite a lot of under predictions from our model. If you look at the right column, these are the maps of the case study area. 1, 2, 3 correspond to Station 1, Williams Lake, Station 2, Prince George, and Station 3, Burns Lake. And you can see at these 3 time points, also indicated in the time series plots, you can see how the smoke was dispersed in the area. At first, it is very kind of concentrated in the Williams Lake area where the actual fire was very close to. And then the smoke kind of dispersed to the second station, Prince George, and finally reached Burns Lake here. So you can see the model kind of capture the temporal and the spatial changes in smoke. And then in case study 2, you see that similarly the time series plots here, again, it's also the predictions follow pretty well with the observations, and under prediction most of the time when the concentrations are high. And here you can see at this time point the entire greater Vancouver area was covered by very thick smoke, and then the smoke kind of diffused and remained pretty intense in the Whistler and Squamish area where the fire was. Okay, so now we have a I think pretty good model that can give us all the population exposure to wildfire smoke, to PM2.5 during wildfire smoke seasons for all the populated areas in BC at the time scale that we need. And the second, so the next part will be to assess the health effects of these subdaily exposure. So to study the health effects of wildfire smoke exposure, we usually need a pretty large population and a pretty long study period because wildfire smoke is sporadic. It comes and goes quickly, and it does not always affect only one region. So you need a pretty large data set to detect any health effects from wildfire smoke. And one of the best way to have that kind of amount of data is to use the administrative health data. Currently, the data that have been used in wildfire smoke studies include things like the medication dispensations, physician visits, emergency room visit, hospital admission, or mortality. But the limitation of these data for our purpose is that most of these data only have the dates of the events instead of the exact time of the day of the event. So what we used in this study is the ambulance dispatch data. In BC, the Emergency Health Services is the sole provider of ambulance service in the province, which means that if we can access these data, we'll have a population-based study that include all the population in the province. And then in this data set, each dispatch call has the exact location as latitude and longitude recorded, and also the time down to minutes and seconds of the emergency calls. And we also link these dispatches to any subsequent hospital admission if there's any available. And one very unique feature of this data set is that the causes of the calls could be measured at 3 different time points. So imagine when you call the ambulance, first you will talk to someone at 911, and that person will, based on what you tell them, they will assign an ambulance dispatch code to this call to indicate why you're calling. And then when the ambulance arrived, the paramedics will assign a paramedic assessment code based on their examination of the patient. And then if the patient needs to be admitted to hospital, they will have a hospital diagnosis code assigned by a physician after the admission. So for one single call, there can be up to 3 measures of the outcomes or the reasons for the call. And all these 3 measures, they have their own advantages and disadvantages. For example, the ambulance dispatch code, they are 100% complete. So each call will have an ambulance dispatch code no matter what. And then, but for paramedic assessment, there's only about 70% of the calls will have a paramedic assessment code attached to them, because that field is not a required field for the paramedics to fill out. And then of course, not all the calls will lead to a hospital admission. So in our data set, only about 40% of the calls were linked to a hospital admission and have a hospital diagnosis code. Excuse me. And also, if you're talking about how close this outcome measure is in time to the exposure, the ambulance with dispatch code and the paramedic assessment code is definitely a lot closer compared to the hospital diagnosis, which can happen hours and even days after the call. So it's actually, there may be a lot happen between your exposure to wildfire smoke and the measure of the hospital diagnosis. And then they are also different in that the ambulance dispatch code was not measured by a medical professional. It's only based on what you tell them, and the callers are usually not a medical professional, so there can be a lot of uncertainty there. And finally, there is also difference in the specificity of the measure. So for ambulance dispatch code and paramedic assessment code, they are usually pretty broad category of symptoms. For example, it can be like breathing problems or chest pain, which may not be very specific to any disease or conditions. But for hospital diagnosis, it's usually pretty specific. It's down to like what exactly is the disease and what subtype of the disease even. So they have very different specificity here. So because these outcome measures can be pretty different, in this study, I will first assess how these 3 measures agree with each other, so that we can have some confidence on are they talking about the same thing at all? And then we'll look at them separately to look at the exposure response relationship and the lag response relationship, treating these three measures as separately. Then we'll talk about it more later. So here, we'll first see how these three measures agree with each other. Here we compare the ambulance dispatch code with the paramedic assessment code. So if you can look at the first bar here, it indicates the ambulance dispatch code as breathing problems. And as you can see, most of the breathing problem calls correspond to asthma, COPD, or other respiratory, so in bluish color categories of paramedic assessment code, which is a good thing because we kind of want it to be breathing problem to be corresponding to something related to respiratory conditions. And on the right side of the bar indicates the diabetic problems, and it also corresponds mostly to the diabetic problems by the paramedic assessment code. And there are very similar situations in these cardiovascular diseases related conditions. So it's giving me a bit of confidence on these measures. And then here is the relationship between the ambulance dispatch code and the hospital diagnosis code. And you can see that their corresponding relationship is a little bit weaker than the one that we talked about before, which is kind of understandable because there's a lot more happening between the call and the hospital admission. And also the severity of the cases can be different as well. But still, you can see that a very large chunk of breathing problems correspond to respiratory-related diagnosis. And same for diabetics, strokes, and chest pain, mostly cardiovascular related. So most, generally speaking, they have this internally corresponding relationship. And to assess the relationship between wildfire smoke exposure and the ambulance calls, we use a time-stratified case crossover study design, which briefly is a way that you compare the exposure on the case day when the ambulance call happened with the exposure at the same time of day, same weekdays, in the same calendar month. So you compare the case day exposure with the average of the control day exposures and see whether the exposure on the case day is higher than exposures on control days on average. So that's a very simplified way of explaining case crossover study design. In conventional epidemiology studies, we usually use a linear regression model to assess the effect of the exposure. So it's usually looking at just the relationship between the exposure and the health response. And you can only have one lag in the model. So you can either study the exposure on the same day or the day before, but you can't really study them both in just one model. But one of the main goal of our study is to look at the lag-response relationship. So we want to know how long does it take for an exposure to lead to a health response. So we use a model called distributed lag nonlinear model, which in this model you can simultaneously look at the exposure response relationship and the lag response relationship. And here are the results, some of the results from the study. And these graphs, you can see the on the left columns, they are the lag specific odds ratios. So it's a the effect estimates for each lag. And on the right column, they are cumulative odds ratios. So it is the effects that's from the exposure cumulatively to that time point. And we also look at, as I mentioned before, the 3 different measures of the health outcomes. Here you can see that both the ambulance dispatch code breathing problem and asthma COPD from paramedic assessment, that we see an effect within an hour or after the exposure. So it's a pretty immediate effect after exposure. But for hospital diagnosis of asthma and COPD, the effect kind of showed up roughly after 24 hours of exposure. So there's some kind of differences between these measures, but for these two, we see pretty immediate effects. And then for heart diseases, we don't see anything in ambulance dispatch, but and quite immediate effect in myocardial infarction and ischemic heart disease from both the paramedic assessment and hospital diagnosis. And for stroke, you see the ambulance dispatch, we have a pretty immediate effect shown here. But for paramedic assessment and hospital diagnosis, both the effects showed up about 24 hours after the exposure. And for diabetes, which is actually one of the most interesting results from this study, is that we see very consistent effect for ambulance dispatch and paramedic assessment of diabetic problems around 24 hours after exposure. Although nothing was here in hospital diagnosis. This is interesting because it's one of the very rare findings of diabetic exacerbation of diabetic conditions from air pollution. And there's only one previous study in Australia where they also find this very similar effect as what we find here. And one of the reasons for the now finding in hospital diagnosis may be that the ambulance dispatch and paramedic assessments are usually like they are actually hypoglycemia or hyperglycemia, and they are usually pretty easy to treat as seen, so they may not necessarily lead to hospital diagnosis. And we still need quite a lot of investigation on why there's this difference between different measures of the health outcomes, why the lag response relationship is different for ambulance dispatch code, paramedic assessment code, and the hospital diagnosis code. But one possible reason that I can think of is probably the severity of the conditions. So only the most severe cases will be linked to hospital admissions. And if we stratify the study, the cause that has a breathing problem code attached to them, by whether they have any hospital admissions attached. So there's no hospital admission at all. There's any kind of hospital diagnosis, or there's a hospital diagnosis that's also related to respiratory conditions. So if we stratify them by these three categories, you can see a very different lag structure. Can see the one without any hospital diagnosis, which may be the less severe cases from the breathing problem cause. Their effects are pretty immediate and decrease over time. But for those that are probably more severe cases, they actually showed the effect actually showed up. It takes some time to show up, and it became significant around 24 hours after the exposure. So there can be several different possible explanations on this. Maybe the severe cases resulted from longer exposure, so they need larger cumulative exposure for them to happen. Or they just need a longer time to develop once they get exposed to the wildfire smoke. Or even it can be that because they delay in calling the ambulance, which leads to more severe cases. So these are some of the possible reasons for this to happen. And here's a summary of what we have talked about. So the odds of respiratory and cardiovascular dispatches increased mostly within 1 hour of exposure. The odds of diabetic dispatches increased 24 hours after exposure. And the three measures of courses agree reasonably well, but the lag structures differed by measures. Some limitations of the study. The awesome 1 hour, because it's trained with monitor PM2.5 data. So they're not strictly specific to smoke. Although in Vancouver, because we limited the study period to summer, the wildfire season, wildfire smoke is almost the only major sources of extremely high PM2.5 events. And also empirical models relies on historical data. So the relationship was trained with historical data. So its performance is unknown if the situation is unprecedented. So you have a model that was trained with one set of data, but if your new data is very different from what you have before historically, then its performance is pretty uncertain. And also, the ambulance dispatch data also have its limitations. There are some missing data in it, so not all the paramedic assessment codes are available for all the calls. And there's also a lag time between the onset of health conditions and the time at which people make calls. Although this is kind of limitation for all the administrative health data, which that you have to assume that the time or the date recorded for that physician visit or ambulance call is the time of the onset of the symptoms or the disease, which is almost always the true, which is not, always not true. And some implications for health policy from my study. First is that interventions during wildfire smoke events should be implemented based on 1 hour average. So one of the main tools we use in Canada for communicating the health risk of air pollution to the public is the Air Quality Health Index, the AQHI. But the AQHI is based on 3 hour rolling average of 3 pollutants, and PM 2.5 has the lowest weight in the equation, so it's not super sensitive to the changes in PM 2.5. So a lot of communities in BC regularly affected by wildfire smoke feels that the AQHI does not always reflect what they are actually experiencing in their community with air quality. So at the BC CDC, we developed an algorithm called AQHI Plus, which adds another equation that's only dependent on PM 2.5, 1 hour average PM 2.5, so that the AQHI plus value will reflect more about PM 2.5 hourly changes in the area. And here is an example of how what a difference it will make to the AQHI when we implement the AQHI plus. So first, you notice that the warning, the higher risk will occur earlier than the conventional AQHI, and also some of the peaks that would have been missed by the conventional AQHI will be captured by AQHI plus. So this has been implemented for I think more than a year now. And it has been, the feedback that we've been getting is pretty good. And second, another implication is the importance to have reliable smoke forecasts. So because we know that the effect of wildfire smoke exposure is pretty immediate, so even real-time measurements of smoke concentrations in a community may not be fast enough, may not be timely enough for us to take action and reduce exposure. And we need to have reliable smoke forecasts so that we know before the smoke actually comes, so that we can take actions and be prepared for the smoke exposure. And also, for both public health professionals and individuals, especially individuals with conditions that make them more vulnerable to wildfire smoke exposure, and we need to prepare in advance and take prompt action during wildfire smoke events. For example, we can have a HEPA filter system at our home so that we can create a clean room when there's wildfire smoke events. We need to stock up our medications if we need it, and also seek medical advice promptly if we feel unwell. And speaking of vulnerable populations, one of the implications from my study is that people with diabetes should be included as vulnerable populations. So, so far, most of the time when we talk about vulnerable populations, we know that there are, for wildfire smoke I'm talking about, there are infants and young children, pregnant women and unborn children, elderly, people with chronic conditions, including respiratory diseases and heart diseases. And diabetes show up sometimes in some advice, but not all the time. But I think with this added evidence, people with diabetes should be on that list. And that's it. Thank you very much.
Thank you very much, Angela. This was impressive and absolutely superb presentation. So with that, we have about 5 minutes to take in questions for Angela. And for those of you who are interested, she is staying around a little bit, or can be reached by email.
Cool. Well, thank you so much. That was really terrific. I'm new to the province, and I really appreciated the explanation of all the different ways that you estimate exposure to wildfire smoke. I had a question about the second piece, which was you had all these really interesting plots from your distributed lab models showing. I'm not thinking of any in particular, so you don't have to go searching.
Okay.
But I was curious how you chose 50 hours as sort of the maximum lag period that you looked at. And you have, particularly on the end there, it looks like you almost have this like linear increase over time. And then I was also, my understanding is that there's a lot of different ways that you can choose to sort of constrain the lag function. I was curious how you get that choice as well. Thank you.
Yes, thank you very much. That's a very good question. So as you mentioned, it is actually it's up to you to decide what's the maximum lag that you use in the distributed lag model, and we chose 48 hours. Based on the previous literature in wildfire smoke studies, most of them found the largest effects in same day exposure or lag to 2 days. So that's why we set that lag up to 48 hours. It's based on the literature on the daily average exposure studies. And because most of them, although they look at, for example, same day, lag 0, lag 1 day, 2 days, 3 days, or up to 7 days, most of them found the largest effects on 0 to 1 or 0 to 2 days. So that's why.
I do have a question.
Okay.
I'm curious about looking at stratification of your analysis, let's say by sex. Do you see any differences between women and men? Do you see any differences in different age categories? And if so?
I have not, but we definitely can. We have the data, but so far I just want to focus on the lag response relationship so that it does not jam too many plots into one paper. So that's probably coming in the future. Thank you.
Just watching the Apple announcements yesterday. I'm excited about they're going to be monitoring noise, making noise data available, like Apple Watches to researchers. So got me thinking about all these new data sources that will give you a much greater granularity over time. I just thought of going forward, like be your ideal kind of measure of some physiological marker or something. You could do something feasible and reasonably practical, given all the new data that's coming.
Yeah, I think it's becoming more and more about like we have too much data in the end. Like, so it's, I think the decision will be at that point when we have more and more finer and finer time scale of data. The issue will be how to piece out all the noises and how to handle the volume of the data and how to reduce the amount of data so that we can actually find something meaningful from the big data area. And yeah, I think that will probably solve the problem at which the onset of symptoms will probably be very accurate if people remember to take their apps out and record them immediately after they feel their symptoms. So yeah, so that would be interesting era and a completely different era for our research as well.
Okay, please help me thank Angela for the presentation today.